Today I will continue on the clinical or diagnostic utility of intelligence test, and the first topic that I will cover, that will be a type of revision for you, that how we can differentiate between intellectual deficiency and deficit. And for inferring deficit we must have knowledge of the IQ level before morbidity, before illness, before psychopathology. So how we can estimate the premorbid IQ, and then using these informations, how we use scatter analysis to infer clinically and diagnostically useful information. These are the three topics that I will cover today. So in the last class, I differentiated between the two terms mental or intellectual deficiency and mental or intellectual deficit. If two individuals, they are performing equally poor, say they are having a score of 69 below 70, it may be an indication that he is a mentally challenged person and therefore he is having mental or intellectual deficiency. And it is also likely that because of brain damage, because of psychopathology or some other factors, he has lost his intellectual capacity. So, what I discussed in the last class, that the two key terms are that intellectual deficiency suggests lack of the development of intellectual resources during the course of development, whereas intellectual deficit indicates that the individual was having some intellectual resources, but those intellectual resources have been lost, say for example because of brain damage, or that intellectual resources or capacity is with him, but because of different psychopathological conditions, stress, anxiety, negative emotions, he is not capable of using those intellectual resources. So these two conditions, either the intellectual resources had been lost permanently, say for the brain damage because neural regeneration is not possible as of now. We have not developed any technology to regenerate neurons. So that will be a relatively permanent loss. That is also intellectual deficit. But in case of pathology, psychopathology, the intellectual resources may be there, but because of the psychopathological condition, the individual may not be able to use those resources, and therefore he or she may show low scores, low performance on intelligence test. And for clinical utility, we need to differentiate between these two conditions. So we have to learn the techniques and procedures that can differentiate the intellectual deficiency from intellectual deficit. Whenever we infer intellectual deficit, it implies that some psychological, psychopathological, or neurological factors are there that has impaired the intellectual functioning. So the basic assumption in the diagnostic use of clinical test, and when I am saying diagnostic use other than diagnosis of mental retardation, is that certain personality traits including pathological traits can influence the intelligence quotient or the IQ of an individual, and thus can change the subtest score profile of that individual. But you will be able to recall from previous class that when the low score on intelligence test performance is because of personality traits, pathological traits, neurological damage, then the influence of such factors, say for example psychopathology, will not be global. All the subtest score will not be equally lowered. but it will be limited to certain specific cognitive domains. And therefore, it will result in low score or low test performance on some subtest and high or better performance on other subtest. And that you saw in this pictorial diagram. The left one and the right one, if you will average, they will have almost comparable IQ. But the profile of the left side individual is that he is having almost comparable score across all the subtests, though it is lowered. It is near the below average line. On the right hand side, you can see the individual who is showing poor performance on subtest 1 and subtest 2, but is on average and above average on subtest 4 and 3. So here we can see a global decline. So global decline will indicate intellectual deficiency. But here there is a selective decline. So this selective decline will suggest intellectual deficit. In other words, you can say that in intellectual deficit, the subtest performance will be scattered, and therefore you will learn in the next few slides how to do the scattered analysis. But as you might have noted that intellectual deficit assumes that the individual was having average or above average IQ. Let me stop the class. Some drilling is for differentiating intellectual deficiency and deficit. We must have some knowledge of the IQ level of the individual before he presents himself or herself before the clinician. That is the premorbid IQ. So when he came with some psychopathology to us and we are assessing his or her intelligence, then if we are having some estimate of premorbid IQ, and then we can compare if he is showing poor performance compared to the IQ level before illness, before psychopathology, then we can directly infer deficit. But you will learn that it is really very difficult, and therefore the other way to differentiate is to see whether the performance is scattered or it is showing a global decline. This is the another way of inferring whether the case is likely to be a case of intellectual deficiency or intellectual deficit. So estimating premorbid IQ can be done by use of previous records. In most of the Western country, at some level of school admission, college admission, they do intellectual assessment. So from those records, the IQ score may be obtained, but here in Indian context, it will be really difficult. But even if we are able to have the premorbid IQ from past record, it will not be very useful because we cannot assure that when the IQ was assessed, the individual was really free from psychopathology, because he or she might have been assessed for IQ but not for psychopathology. Thus, we all are left with the option to estimate the premorbid IQ, because assessing the premorbid IQ or accessing the premorbid IQ from previous record will not be that much useful. So there are different techniques to do so, and I have clubbed them into 4 categories of estimate. The first one is the best performance method. In this approach, we assume that the individual who has scored highest on some of the subtests or one of the subtests on any intelligence test, say for example Western Adult Intelligence Scale 4, that highest level of functioning may be considered as equivalent to the highest level of functioning in his her day-to-day life, and this may be used as a estimate of premorbid IQ. But this method has limitation because you all have learned by now that we all show some variability is scattered in our test subtest score performance. And when we are taking only one test on which an individual has performed the best, he or she has scored the highest, this approach will not take the normal variability, not the abnormal scatter. Normally we show some variation, we will not score exactly same on all subtests. So this normal variability among subtests is generally ignored, and therefore this method has often been shown to overestimate the premorbid IQ. Why overestimate the premorbid IQ? Because we are choosing the best performance that will be the highest IQ for that individual. And thus, if we are analyzing the difference of the current IQ with this estimate of premorbid IQ, we will be systematically overestimating the intellectual impairment or deficit. I am not reading these names, you might be seeing. These are based on research evidence. It is documented. Another again. So the second method is to select that subtest of any intelligence test, say for example Wessler Adult Intelligence Scale 4th edition, that is considered to be relatively less sensitive or insensitive to the effects of brain damage. And vocabulary and information has been suggested by many researchers as this type of subtest, which is least influenced by brain damage and psychopathology. So vocabulary and information subtest score of Wessler scales can be considered as best indicators of the premorbid intelligence. Why? Because we are assuming that these tests are relatively less influenced on non-influenced by the effects of psychopathology and brain damage. So it is well documented that vocabulary is among the most resistant of the Wessler subtests. But there are some issues with this because researchers have noted that performance on this test may also be significantly impaired in range of clinical condition. Range of clinical conditions means in a wide variety of clinical conditions, and it is therefore likely to seriously underestimate premorbid intelligence. Similarly, the information subtest scores reflect a person's general fund of knowledge. However, this score may also be misleading because this score is highly influenced by the educational background, educational opportunities. So one who is coming from good SES, having good opportunity to get education and training, will have different level of information subtest score, though his or her IQ may be same as of a low SES individual who is having poor or less opportunity for education. So the second estimate is also not considered very good estimate. The third is using some overlearned skills. So you all have noticed that overlearned skills are generally not impaired because of psychopathological conditions. The person can walk and talk, even having severe psychopathology. And generally, under this category, some standardized reading tests are used. Why? Because these reading tests have been found to be strongly, highly correlated with test of intelligence. I have put some name. This is NART. This stands for National Adult Reading Test. NAART. This stands for North American Adult Reading Test. WRAT stands for Wide Range Achievement Test, and there is one subtest of WRAT, that is reading subtest. So these reading subtests in Indian context, we can take Indian versions of the reading subtest and use this as an estimate of premorbid IQ. But this method is also having several limitations because the correlation of these tests with intelligence is far from perfect. It is not zero point 0.9 or something. It is highly correlated but not perfectly or near to perfect correlation. So it will not substitute the intelligence score. So the final method is called actuarial method. The actuarial term is basically derived from the noun actuary. Actuary means a person who is well versed in analyzing numerical analysis, analyzing data, and generally it includes statistician. So we can say that actuarial method means a statistical method, and that statistical method often use a form of multiple regression. And in this actuarial methods, several researchers have tried to empirically develop regression based statistical equations to estimate premorbid IQ, but this requires only information on demographic data such as age, sex, race, education, occupation, nothing else. So these informations can be easily obtained, and we can use those actuarial regression equations or actuarial techniques to estimate premorbid IQ. I have mentioned one which is very popular, Barona index. But remember, this has been developed in the context of America. This is the Barona index. Estimated VIQ, verbal IQ, is equal to, this is the constant, if you have learned regression, 54.23 plus 0.49, this is the weight of age, plus sex, plus this much race, plus this much education, plus this much. This will estimate the verbal IQ. Similarly, estimated PIQ, the constant is 61.58, which implies that verbal IQ may be slightly lower than the performance IQ, and this is the equation for full scale IQ. I am just showing, and I will share the PPT so you will have access to this. And what should be the numerical value for different race, education, occupation? Barona has defined that also. For example, if you are a female, then you will get a score of 1, and male a score of 2. It means Barona has given more weightage to male compared to female. So race, if you are white, American say, then you will get 3, black 2, others 1. So again, here is, I am pointing out this because though it has been empirically derived, it has been derived in a particular cultural context, and it may be culturally biased and giving different weight to different conditions. So similarly, occupation, so professional, technical, sex, these are just you see. So if you are say reason, then if you are living in southern part of US, then 1, and western part of US 3, north central 2, and northeast 4. So if you are living in, and look, from this you will infer that this formula is applicable for more or better applicable for US. So we cannot use here in India. We need to estimate our own equation for doing that. So using this, we can do the estimation of premorbid IQ, and this is widely used in research even today. Now, as I mentioned in the beginning of the class, I have covered two topics: the estimation of differentiating between intellectual deficiency and deficit, differentiating method of estimating premorbid IQ, and now I am entering into the realm of scatter analysis and how we can extract diagnostically useful, clinically useful information to make diagnosis. So the techniques that I will discuss is in two categories: the group comparison technique. In this, what is done is that we compare the patient group with a matched control group, and then the group mean may be considered as some estimate, and using that mean we can compare the score of the individual. So the average IQ of the control group is taken as an estimate of premorbid IQ, and based on that we do. I will share little more detail on this. And subtest scatter analysis, it is also called pattern analysis. These are the classical traditional methods of doing uh, uh, the analysis of intelligence test score for extracting diagnostic information. In this, intra-individual means the comparison is done not. The first one is inter-individual comparison. We are comparing a healthy individual with a individual having some psychopathology. But this scatter analysis or pattern analysis is an intra-individual approach in which the comparison is done within the individual on various subtest scores. And the relative difference in the performance on different subtests compared to some estimates of premorbid intelligence is taken as an index of psychopathology. Higher the difference, higher the scatter from premorbid IQ, greater the chance that the individual is having psychopathology or brain damage. Apart from these two broader techniques, there are some other techniques that I will discuss. But for having good clinical information, having more reliable conclusions based on intelligence tests, as I mentioned, that the IQ test should be interpreted in the context, and therefore for the context we must note the response time, because some individual may take more or less, though all the tests of intelligence tests are not timed. Some tests are timed, but some tests do not fix any time. One can take as much time as he or she wishes. But if we are doing testing for clinical purpose, then it is better to develop a habit to note the response time, the response rate, amount of productivity, form of the response, projective content. Sometimes people say many things and you may infer that they are projecting something on this. Suppose I am showing blog design and then he regresses into the childhood and shares something about his past childhood. When I was child, I was doing this and that. I will make a note that this blog design test has activated the past schema. Similarly, we can note the attitude, emotions, other verbal, non-verbal reactions, and you just make a note, because I know that you can ask something about this, but we should have a note of all these information. This will help us to better interpret the intelligence test performance as well as the scatter analysis in this context. Now, I have mentioned this Rapaport's approach because Rapaport initially did a lot, and these are the approaches which I am mentioning is basically proposed by him. And I have already discussed group comparison technique, and where we compare the IQ of a healthy individual with IQ of the individual having psychopathology. This approach has been proven to provide diagnostically useful information. For example, in a classical study, Robin used voice, that time voice 4 was not there. So don't ask why he not used voice 4. Robin observed that with increase in severity of psychopathology, the overall IQ was lowered compared to the control group. He found that as compared to controls, the IQ is 101, it is average IQ. Neurotics were having a lower score on the average, 94.4, and schizophrenics were having even more lower IQ, 88.7. So, taking this as a premorbid estimate, we can uh, compare the IQ of the client. But generally, this group comparison technique is used for research purpose where we are following nomothetic approach, means we are conducting a study on more than one individual. But for clinical purpose, this method, the average scatter and other methods of scatter analysis are more useful. As I mentioned in the earlier class, that if we can compute some measure of dispersion, measure of variance in the subtest score performance, like standard deviation, like average deviation, and if this standard deviation and average deviation is high, then it is showing that the individual has shown scattered test performance. She might have scored high and very high on some test and low and very low on the other. But when the average scatter as indicated by standard deviation or average deviation is low, it means the client has performed almost comparable, almost equally well on all the subtests. So, low standard deviation, low average scatter is indicative of normal test performance, and high scatter is indicating the likelihood of having psychopathology. Greater the variation, greater is the likelihood of having psychopathology. So this is not the scatter of individual subtests, but Rapaport suggested that we can see how scattered a test performance, subtest performance is. So scatter of individual subtest from some estimate of premorbid intelligence quotient has also been suggested. And he suggested three categories of scatter. Vocabulary scatter, where we use vocabulary subtest as an estimate of premorbid IQ and then compare the test performance on other subtests. So, any elevation on depression in subtest scores compared to vocabulary is interpreted in that way. If the IQ is lowered, we will interpret lowering of that cognitive intellectual function which the test is representing, and we will also infer that there is likelihood, because if it is intellectual deficiency it will be lower globally, but if it is scattered, some test is showing depression and some test is showing elevation, it means there is a scatter. Similarly, we do mean scatter. The only difference from vocabulary scatter is that we compare the mean of all the subtests. So we do not take vocabulary as estimate of premorbid IQ, Neither we test the highest performance or highest test score as indicator of pre-morbid IQ. What Rappaport suggests that compare the subtest with the mean of all subtests. That can be better representative of pre-morbid IQ. But later on he modified this. He said that mean scatter suffer from a limitation that we are clubbing theoretically two distinct types of IQ, the verbal IQ and the performance IQ. So it is better to compare the subtest of performance IQ with the mean of performance subtest and compare the verbal intelligence subtest with the mean of verbal subtest scores. This is called modified mean scatter. These are the traditional classical way of analyzing intelligence test score. The single theme to remember is that greater the scatter, greater the variation, and if there is a pattern of depression and elevation, low and high, then this is more indicative of psychopathology. Other approaches have also been used and suggested in the literature. One is within test scatter. The within test scatter is the difference in the performance of different items. Most of the intelligence tests are arranged, items of the intelligence test are arranged in such a way that more difficult items will come later and easier items will come first. But suppose you are saying that an individual is not doing well or he is failing on easy items but passing on difficult items. This is not the usual and normal pattern. If this type of variation is seen within a subtest, then this type of scatter will be called within subtest scatter, and this is also indicative of some brain pathology or psychopathology. Another approach is the index approach, and Wessler himself suggested an index called deterioration index. And this deterioration index was proposed by Wessler to infer the possible presence of psychopathology or brain dysfunction. And he classified the subtest of his intelligence test into two categories: don't hold test and hold test. Don't hold test means those tests which are not stable, those we are not holding their level, they decline, they normally show decline with age. And these tests include digit span, similarities, block design, and digit symbol. Hold tests are those which do not generally decline with age and tend to remain stable, and that include vocabulary information. You have already heard about this, object assembly and picture completion. So the deterioration index is hold minus don't hold divided by hold. Higher the index, greater the likelihood that individual is having chance of psychopathology or brain dysfunction. In addition to this, some researchers have also tried to identify a profile or pattern of depression and elevation in test score, and that we can call subtest pattern or profile approach. The pattern of elevation and depression in score on all the subtests, and the difference must be 2 to 4 points, then we will consider it as clinically significant. So, for example, some researchers identified a schizophrenic profile. Picture arrangement plus comprehension is less than information plus block design. Why? Because schizophrenics are socially aloof, and therefore picture arrangement and comprehension, they involves a lot of social information, and because of that they are likely to score low. Similarly, object assembly is less than block design. Again, the same reasoning. Similarity is less than vocabulary. If you observe these three patterns, then it is likely that individual may be having schizophrenia. But this has not been very strongly validated, but it has been proved in research that such different profiles are likely to be present in the subtest performance, and that can be used for clinical purpose. Now I will conclude today's lecture and then I will provide you some time. So overall, currently, how we interpret the intelligence test in clinical setting. So we do it at different levels. The first level is that we full scale IQ or global composite level. First we have to see whether the overall IQ is below average, above average, like that. There we will start if someone is having below average IQ, then we will start further analysis that whether this is because of intellectual deficiency or deficit. Second level is that we will see the specific composite level, say verbal IQ versus performance IQ. If verbal IQ is say very low, it is below average, and performance IQ is average or above average, then it is likely that individual might be having left brain damage, because left brain is largely responsible for verbal test performance. If the opposite is the pattern, say one is having very poor performance IQ, say below 70, but the verbal IQ is 100 or 101, then it is likely that he is having right hemisphere damage. So this is the second level. Then we will come to the subtest level. We can do the scatter analysis as I suggested. Then at item level we can do the within test scatter, and we can also try to interpret the item contents. And one thing is that different test and subtest represent different cognitive functions, cognitive capacity. We can also interpret the test scores in terms of cognitive capacities. So this is the overall. I have discussed the methodology only. When I will discuss bias, when I will teach bias, I will test the subtest, and then in the context of bias, I will again tell you that if there is a scatter on any subtest, what is the possible clinical implication or indication of that. So thank you very much for listening me, and if you have any questions or query, you can ask.